Menopause. Of all the things we experience as women throughout our lives, for me, this has been a most challenging time. I have been cranky, had feelings of bitterness, been forgetful, and don't even mention the hot flushes. I just mentioned the hot flushes, didn't I? Ripping my clothes off in the middle of the night and Barry thinking his luck has changed. Well, don't even think about it, mate. Dr Kelly Teagle is passionate about helping women through what can be a most confusing, frustrating and sometimes impossible change of life that is menopause. Her telehealth menopause clinic, WellFemme, was established to make it easier for women, particularly those living in regional and remote areas of Australia, to access high-quality information, care and treatment from their own homes. I hope you enjoy hearing from Dr Teagle. Dr Kelly Teagle, thank you so much for joining me. Now, I must say, I hope you're not going to be disappointed in me because I know you've been interviewed by Tara Brown, and I know Tara Brown, but I'm really, really keen to hear all about WellFemme and have this chat with you about menopause, or as I like to call it, menopause, because, man, you better pause before you come near me.
Yeah, that's sounding like you've got reports of a very similar experience to lots of my patients. But don't worry, Tara Brown, I didn't really get to be all that deeply interviewed by her, so I can't say I'm an expert on interviewers. I think so far so good. I think you'll be fine.
Oh, that's good. I'll fool you. So, Kelly, I want to start about asking you about WellFemme because it came about through your experience and lack of knowledge when you went through early menopause, didn't it?
Yeah, absolutely. I have this experience myself that I was particularly young. I was 42 when I was going through the worst symptoms. And for me, it was I was incredibly irritable. I'd get in these sort of irrational rages, and I had 2 young children and I was tired and I'd been through a marriage breakup. So it was kind of, I expected that was quite normal under the circumstances, but it wasn't until I started to get the hot flushes that I really put it all together and went, oh, hang on a minute, could this be something else? And of course, as a women's health doctor, it was on my radar, but you just don't think of it. It's just not something that you automatically think of, and particularly at such a young age. So, for me, it was a big wake-up call. And I happened to be working at a family planning organisation and doing some menopause clinics. So it just led me to dive a bit deeper into everything and realise how poorly treated women in Australia were with respect to perimenopause and menopause.
I'm ashamed to say I didn't even know what menopause was until I was, going through it, and just because people don't talk about it, and I had lost my mum as a little girl, so I didn't really have that experience or that other person's experience to tell me about it either, apart from my auntie who went through menopause or started to go through menopause when she was 45, and she said to me, I don't know, I was probably 35 or something, you better watch out because you might go through early menopause too. Yeah, whatever, But anyway, we will get on to the menopause, but tell me about WellFemme, how it works. And
yeah, I'll do that. But Kelly, don't feel ashamed of the fact that you'd not heard about perimenopause. That is incredibly common. And in fact, I was just at a menopause round table at Parliament House recently, and Shelley Horton was one of the speakers. She's a journalist on Channel 9. And she told her own lived experience of what was going on. Now, she's an empowered, woman who's not shy. She puts herself out there. She's around and across a lot of stuff, but she had no idea that perimenopause was a thing either, and it hit her like a Mack truck. So, it's a really, really common thing. And despite the fact that, you've got a reason why you wouldn't have had any advice from your mother about this area, it's just something that women don't tend to talk about. We tend to share experiences around what it was like for us with puberty and our periods and having babies. and all of that kind of thing. But no one talks about menopause. And I think that the time has come to lift the lid on that. And I think people are starting to talk about it a whole lot more. And anyone watching the media recently will know that.
Just on that, like, it's not just for us either going through it. It's for our families because, the kids are, you're so forgetful, Mum. And what's wrong with you? Why are you so cranky? And it's, yeah, and then you just, and like you said, you get irrational and, it's, so, to educate our families and in particular our husbands. And, sometimes I think, how has my marriage survived and how do other people's marriages survive, especially if they don't have the knowledge and if they, don't talk about it with their husbands or they don't want to admit to their husbands that.
You're touching on something really important here, because it's no good just actually speaking to the women and having the women aware. I think it means that we have to educate everybody about, the whole life cycle for women. And by women, I mean anyone born with ovaries, basically, because not all of them identify as women, of course. But anyone born with ovaries will experience menopause at some point. And the people who love them, their communities, really need to be aware of how this will impact. Their workplaces need to understand how this might impact, because sometimes their most key staff are people of menopausal age who might be being, experiencing all of these debilitating symptoms that are really impacting on their ability to work and function. So, yeah, it's a community-wide education issue, I believe.
I noticed the difference between my husband, Barry, and his brother, Mac. And Mac and Gail have been married for, 20-something years now. And Gail has no arms. So Mac does everything for her. So if she goes to the doctor, Mac goes too. So Mac knows everything that's going on with Gail. And, their doctor sits down and talks them through it and tells them. So Mac is very well versed with everything. And the other day he said, I think you should just all go and get on an island by yourselves until you're over it. And Gail said, you wouldn't be able to work the computer, Mac. He said, I'll send the computer with you.
And that's probably not a bad solution if it was just going to be a couple of years. But when you think about, the menopausal transition, as I like to term it, the hormonal changes can start to happen anything up to 10 years before you actually have your last ovulation, and then forever after that, beyond that, you're classified as being postmenopausal. But the hormonal changes that are causing symptoms and sometimes really impacting on function could be 20, 30 years of a woman's life or more. So, we're not talking about, just go on a holiday to an island. We're talking about a third or a half of a woman's life potentially.
And that is a thing that surprised me too, is how long it hangs around for. Like, I can remember back probably in 2014, I was, being really, my life just changed, and I didn't really know why. And it's now only looking back that I think, well, that's why. And, I'm still going through it. So, yeah.
But, the thing to notice, I guess, about that, and the thing that's really empowering, is if you actually recognise it, if you accept it for what it is, and you know what your treatment options are to minimise the negative impact, there's actually a lot of positive things about this stage of life. And if you can harness that, it can really be an incredible time of life. It can be the best time of a woman's life. So it's just a matter of having that education around it, knowing what your treatment options are, and looking and focusing on the things that you can do rather than the things that you can't do.
I have found that the information can be sometimes very, very confusing. One doctor will tell you you can't have HRT because there's a history of breast cancer in your family, and then another doctor will tell you that you can, and then one other one wants to put you on antidepressants. And so, I really take my hat off to what you're doing. You're just focused totally on menopause through WellFemme and, reaching out to people in all corners of Australia. And I know your passion is regional and remote women, and gosh, you're exactly what we need.
Yeah, well, you're really touching on the reasons why services like WellFemme are so important, but also the reason why we have to exist at all. Ideally, women should be getting the information and treatment they need from their own local doctor. They rely on their GPs for a good breadth of knowledge, but unfortunately, it's not been well taught to GPs. And it's not been well educated to patients. And there's been a lot of misinformation over decades now about the safety aspects of hormonal treatments that have really scared people off from this space, not just patients, but GPs as well. So it is quite confusing. And for that reason, I think we do need the guidance of some specialised GPs to be able to help upskill the general practice population, and also to service those women who can't get the help that they need at local level. And they could be even in urban areas. Like, I originally started WellFemme because I recognised this problem that women in rural and remote areas may have a passing parade of locum doctors or have a great deal of difficulty even getting to see a GP, let alone one that's knowledgeable about menopause and perimenopause. So knowing that this type of care can be very well delivered just through a history and conversation over either video or over the phone, that led me to think, well, we should be trying to reach those women by telehealth. And of course, this was going back in 2017, 2018, when telehealth really wasn't a thing yet. So it was quite an idea at the time to be putting out there, and people sort of thought it was a bit weird and maverick, and patients would be saying, is this a real doctor? Real doctors don't do business this way, do they? So, of course, COVID came along and changed all of that. But, yeah, so I really wanted to reach those women in rural and remote areas, but I also know from personal experience and that of my friends and patients that even in urban areas, they're really struggling to either get in with a GP or find one that has a reasonable level of knowledge about perimenopause and menopause. And there's a lot of inconsistency, misinformation, misrepresentation, and unfortunately, that can lead to women being not treated appropriately.
Kelly, you touched on the support that you offer to the general GPs through WellFemme. But I think, do you have 11 doctors across Australia that work with you through WellFemme? Is that correct?
Yeah, that's right. So the beauty of telehealth is, so if I'd have been trying to start this type of specialised practice in bricks and mortar here in Canberra, I would have been really struggling to find enough doctors to be able to work with me because, doctors who are specialised in menopause care don't grow on trees. The beauty of this model is that I can actually find the best doctors from all around the country, and they can just be working from home to see the patients who need them. So now we're going to be coming up shortly to recruiting our 15th doctor. And we have them pretty much they're certainly all around the country. We haven't got one at the moment in Tasmania. We don't have one at the moment in Northern Territory or South Australia, but pretty much everywhere else.
And I mean, that doesn't matter so much, does it?
Not at all.
No.
Yeah, not at all. And same with managing or educating GPs. We can provide services to support GPs wherever they are. So if a GP wants to manage their own menopausal patient, but they're finding something that's a bit tricky or they're not sure about anything, they can absolutely either refer the patient to us or they can just contact us and discuss the case. We also have some webinars, pre-recorded webinars that are on our website for GPs for upskilling and a contact form for GPs to reach us. More and more we're getting into the space of helping to upskill GPs and also advocacy, which is part of why I was at Parliament House lobbying for a national menopause action plan so that we can actually get a policy framework in place to point the way forward for future funding, really well-targeted services and education for GPs, and making sure that women all around Australia can get the services that they need.
Kelly, I love your pay it forward system as well. So could you just explain how that works?
For sure. Yeah, one of the difficulties when I started WellFemme was the fact that there was no Medicare rebate for telehealth back then. And when you have quite long consultations like we do, so that we can cover a lot of aspects of a woman's, psychosocial situation, medical conditions, very holistic approach to assessment, it takes a long time. So those consultations are pricey, because if we're going to provide a specialised service and give it the time it deserves, we need to be able to pay the doctors well. So this was a sticking point, because what's the point in having a service that's great if your patients can't afford to use it? Luckily now we do have Medicare rebates available, but still there's a big gap, because Medicare does not appropriately compensate through rebates for longer consultations. And so a lot of women still struggle to afford that. So we recognised that this was going to be a problem, and the ones who needed us most may not be able to afford it. The way that we've gotten around that to a certain extent is by offering 1 in 6 of our new patient appointments as a concession or pension card rate. So we kind of average out what we think we need to be charging, and then we added a little bit onto the cost of the full priced appointments to help to subsidise the patients who can't afford the services. So it's kind of like, the women who can afford to pay the full price are actually helping to service women who can't afford to pay the full price. So it's kind of like women helping women sort of situation.
Oh, I think it's wonderful, and that's what makes the world go round, generosity. And, you still have to be able to put food on your table, and you have to be able to run your business to, the best, highest capacity that you can, just to help so many people. So I take my hat off to you. I think that's a wonderful initiative, and, fortunate for women who genuinely are struggling out there financially, but also with, going through menopause. So, Kelly, tell me, for those that haven't started going through menopause yet, what are some of the things to look out for? What are some of the symptoms that...
Yeah. So I explain the menopause transition to women in this way. So you imagine that subtle hormonal changes are starting to occur, perhaps even up to 10 years before you finally run out of eggs. Menopause itself is the time when you've ovulated your last egg, because throughout our life we're gradually running out of eggs. And we don't know that it's your last egg until 12 months down track, when you go, oh, I haven't had any periods for 12 months. So that's kind of the definition of menopause, when you've been 12 months without a period. Now, it does get trickier, of course, if you've had an uterine ablation, for example, for heavy periods, or you've got a Mirena IUD or something like that that stops you from having periods. But we kind of get subtle clues in the symptoms and things. So postmenopausally, you've got quite low levels of estrogen. And the important thing to remember about that is that after menopause, the low levels of estrogen mean that you get rise in your heart disease risk, a rise in dementia risk, and quite a rapid drop in bone density. So these are the things that we stay focused on in terms of future health, making sure that we are advising you correctly about the sorts of lifestyle changes that you should be making, and dietary changes and things to support your body better postmenopausally. And so that's the beautiful thing about getting a good, thorough assessment at the time of menopause, is because you can engage in really, really effective preventive strategies, I suppose. So I love that about this work. The clues, as far as how do we know what's happening to us, though, they may start well before that point of actual menopause. So even if you've got regular periods, if you are noticing worsening premenstrual mood or migraines, for example, it might be actually because your ovaries are becoming less efficient at the hormonal changes that they normally do in a cyclical way. So you might be relatively lacking in progesterone, for example, compared to the estrogen. Your periods can start to become heavier or more painful. And then as things progress along through perimenopause, you might start to see the changes in your cycle. That's the usual thing. Either the cycle's getting shorter, maybe 21 days where it used to be 28, or it might be blowing out longer to 32, 33 days. Your periods might be getting heavier. Then eventually, as you get even further along in later perimenopause, the periods may start to become quite erratic as you start to run out of eggs, and the ovaries are sputtering to a halt by, popping out eggs at random intervals. And that can be the time of really peak hormonal chaos, so that you can really start to get a lot of mood changes. Then, if you imagine it, if your hormones are rising and falling at random times and relative to each other, the dynamic kind of shift is changing all the time. That really impacts on brain chemistry. So it can cause worsening irritability and mood issues, sleep disturbance. The hot flushes are starting to kick in. You're fatigued, you've got brain fog, your cognitive functions sort of blunting off, or your memory. And those sorts of things are super, super common, and actually pretty much at their worst in that late perimenopause and going into early menopause. Because beyond that, when your ovaries are not doing their thing anymore, they're not popping out eggs all the time, then you actually get much more stability with your hormonal environment. So less of that mood kind of up and down sort of stuff happening. But you will find then probably in early post-menopause that's the peak of when your hot flushes and things start to happen. And then as you go along, maybe worsening vaginal dryness, changes to your skin and your bones and things like that. So the spectrum of symptoms really changes a lot through the menopausal transition, depending on what stage you're at. And there are effective treatments available at all stages for the things that you can see and feel, and the things you can't, like your bone density and your heart and all of that. So it's super important to get the right kind of timely advice from a doctor who knows what they're talking about with respect to menopause, and so that you're not, maybe prevented from accessing treatments that might not only help your symptoms, but help to prevent chronic disease down track.
It's like the fun police, isn't it? In action, you're not going to have any fun.
Well, you mean if the GPs are saying, no, you can't have that?
Yes.
Yeah, absolutely. I think that's I really don't like to hear that. I think it's not our job as GPs to be the gatekeepers and tell people what they can and can't have.
Yeah.
It's up to us to help them interpret the huge tsunami of information that they can access on the internet. Some of it is very dodgy information. So, and I mean, really, you can't be getting all your information about what treatment is right for you from a Facebook group. You really need an individualized assessment from a doctor who can holistically assess your own circumstances, your own medical history, your own priority symptoms, and help you determine what's right for you so you can make that choice. And then they facilitate that.
And Kelly, I mean, I know everybody's different, but as a general rule of thumb, how long would you expect perimenopause to last, and how long, post-menopause?
Yeah. How long is a piece of string, Kel?
Yeah. Yeah.
This is a tricky one, because all of these things will be dependent on whether the woman is experiencing menopause at the average age of menopause or not. So the average age of menopause is 51. Most women will go through, or most people with ovaries will reach menopause somewhere between 45 and 55, but about 10% is outside of that range, and 1% are even below the age of 40. So it's not uncommon that people might go through a much earlier menopause. And unfortunately, for some people who might even be in their 20s or so when that happens, that might stop them from being able to have a family. It's super important that people get the right advice about, like if the early signs are there that it could be perimenopause, or that it's something hormonal, and they're much below the expected age, we should be actually checking their hormones early. It's one of the few situations where we do actually check hormones in this space. If they're unusually young, we want to make sure, because that has big health implications for the development of premature heart disease and osteoporosis, for example. But in terms of how long it might last, I guess if you were somebody who was going to be experiencing menopause at the average age, say 51, you could be expecting to start to notice some subtle changes in symptoms related to hormone changes in your 40s, potentially even the early 40s. We have patients coming to us even in their 30s often wondering, are my symptoms related to perimenopause? And sometimes we do offer them hormonal treatment just to see if it helps, and it actually does. So, it really depends on the person. But if you go through a surgical menopause for any reason, say if you've got a really high risk of developing breast cancer or ovarian cancer because of a family BRCA gene mutation, you might opt to have your ovaries removed at a young age, or you might have to have chemotherapy because of cancer treatment, or you might have dreadful endometriosis or something, and where they make the decision fairly early on to remove your ovaries for some reason. There's many medical and surgical reasons why that might happen. And of course, they get thrown into a super sharp and sudden menopause. So their bodies don't have the benefit of that adjustment period with their ovaries winding down. They just kind of go from 100 to 0 overnight. And those poor people do tend to be the ones that suffer with the worst flushes and the worst symptoms, and they can go on for longer because of that.
I didn't know that surgical menopause was a thing until about 2 weeks ago, and a lady who had been through it was telling me, and I thought, oh gosh, there's just so much I don't know, and so many people are affected in so many different ways. With the hot flushes, Kelly, like for me, I had hot flushes for ages, and then they stopped, and I thought, oh, thank goodness for that. And then just as a little surprise, back they came with a vengeance. And so is that quite normal?
It is really common, and again, it usually comes back to ovarian function. So the tricky thing about perimenopause is you don't quite know when you're finished until you get to that 12 months without a period. So you might kind of be going through a phase where you've got dreadful flushes. And often that coincides with a really long gap between your periods. Like you'll notice that it's been 3 or 4 months since your last period, and all of a sudden you're waking up feeling really hot, chucking the covers off. But then all of a sudden you start to have regular periods again and you feel fine again. So it's all part of this winding down of the ovaries, and we can never predict. There's occasionally women who'll say, I was having regular periods right up until when they stopped, but that's less common. It's more common that people will find a change in the length of their cycle initially, followed by some irregularity, and they might actually have stages where their periods are really close together and stages when they haven't had them for 6 months or more, and they think maybe I'm menopausal now, and then all of a sudden they come back. So it's not uncommon.
So is there a link between HRT and breast cancer? Because there has been breast cancer in my family, so I have been told I shouldn't take HRT. So what's your take on that, Kelly?
Yeah, and this goes back to the misinformation thing that I mentioned earlier that's been around for decades because of some sensationalized headlines that came out in the early 2000s that linked MHT with breast cancer. But the data was misrepresented. It actually only applied to an older subset of patients who were inappropriately started on hormonal treatment well past the normal menopausal age, which is not when we use it. So actually, when they reassessed the data, what they realised is that for the vast majority of women who are around the age of menopause, it's actually very effective, the most effective treatment for hot flushes, for example, and very low risk. And in fact, it can actually help to offset the rise in heart disease risk and drop in bone density, and probably even has preventive benefits for the brain as well, maybe even reducing dementia risk. We're still doing that work. So actually, we know that for the vast majority of women, it is actually quite low risk as long as they haven't left it more than 10 years post-menopause to start. There are a few contraindications, however. So, you can't just open slather, go and buy it off the shelf, because anyone who's had a hormone-sensitive cancer, which would include breast cancers, endometrial cancers, and a range of other ones, obviously, you don't want to give hormones to people who have a hormone-sensitive cancer, because if there's any cancer cells in their body, it would make them grow. So people who've had breast cancer can't use hormonal treatment. But in fact, with respect to normal women who haven't had a breast cancer or a hormone-sensitive cancer, the majority of them can actually use it fairly safely. And what we say about it is that any rise in breast cancer risk usually wouldn't occur until at least the 5-year mark, and it would be equivalent to if you were drinking 2 glasses of wine per day. Now, to put that in perspective, if you're 20 kilos overweight, you have double the risk of breast cancer. But, the biggest risk factor is just being a woman, because you've got a 1 in 7 lifetime risk of developing breast cancer, regardless of whether you're on hormone treatment or not. So the increases you get from long-term hormone treatment are very, very small compared to lifestyle factors. And we actually have safer body-identical forms of hormonal treatments that we use these days that actually haven't been demonstrated to increase breast cancer risk. So again, it comes back to the individual assessment for each woman, what type of products they're willing to consider, and the knowledge of the provider to prescribe the things that are likely to be the lower risk options for each patient.
It's good to know, that there are some really valuable options for, all sorts of women, with different health problems. And I love that the fact that it can help with your bone density and your dementia and dementia risks, I suppose. So, yeah.
Yeah, well, that hasn't been definitively proven, but all of the studies that are coming out are really highly suggestive of benefit from that estrogen is protective in a lot of these things. And of course, a lot of women who start on estrogen therapy say that their brain fog lifts almost immediately. So it depends. From person to person, we really can never predict what benefit they're going to get from MHT, and also what side effects they might get from it, because everyone responds differently to different hormonal molecules. So it's just a matter of trial and error. I say to people, these are pretty low risk things to try in your situation. So here's a strategy we could employ. If you're not liking that, we're not married to it. Let's just try something different. You've got a range of options there that we can explore. So it's just giving women options and letting them feel empowered to make choices with the right information.
And Kelly, libido. What happens to your libido?
Mm-hmm. Well, libido is a really, really tricky area because so many things affect it. Now, if you're a bloke and you've got, tons of testosterone, then you've got a much higher sex drive, well into older age. But for women, their testosterone levels are only a fraction of a men's testosterone levels, even when they're at the peak of their reproductive capacity in their 20s and 30s. So as we age, that really declines even further. You've got in your 40s, you've got half the level of testosterone you had in your 20s. So there's even less physiological drive for desire and wanting to have sex. Then you throw on top of that the fact that, at that time of life as women are approaching menopause, they're at the peak of their responsibilities with their family, their job role. They might have aging parents. There's a lot of stress in their lives. They're busy, not sleeping enough, not finding time for self-cares, starting to have menopausal hot flushes and sleep disturbance, feeling like crap, eating badly because they're so pushed for time and craving carbohydrates. How is that woman supposed to feel sexy? Then throw on top of this again, some women might have an issue with painful sex because maybe they've had a history of endometriosis, or they're getting very dry, fragile vaginas because of a lower estrogen level. And, they're finding it much, much harder to become aroused and orgasm as well. So there's kind of no payoff for them in having sex at all. It kind of is the situation where they end up having grudging sex with their partner because they feel bad that their partner always wants it and they're always saying no, but they don't enjoy it, and they're sort of lying there while their partner's banging away and they're kind of thinking, oh, hurry up, I just want to read a book and go to sleep. So, there's all of these, it's not just about hormones, it's multifactorial, there's psychosocial type of things, there's physiological types of things, and we have to unpick all of that to be able to effectively address libido. But the important point to remember is it's not abnormal. It's absolutely normal. The vast majority of women report lower libido, lower sexual pleasure. These things are well treatable. Particularly if you've got sexual pain, that is not okay. So it's kind of normal that you might have a lower sex drive, but if you can become aroused and you can still orgasm, then usually that's showing us that the machinery is all there. It's just a matter of kind of managing how we approach actually intimate situations. But if you've got pain, if you have any kind of, bleeding or anything after intercourse, these things are not okay. They need to be checked out and discussed with a doctor. And it may well be that we can fix that pretty easily with some vaginal estrogens and you'll be off and running. So we have to get onto these things earlier rather than later. If you wait until too far down the track where your vagina is very thin and dry and the labia have all kind of regressed, you can't really restore that back to where it was. You really need to get onto it early.
That's so important to know. And, for our husbands, it's important for them to, like as we were talking before, about educating them so they don't think, oh, she's lost interest in me and she doesn't love me anymore. And when there's actually a physical reason for and a medical reason.
Absolutely. It's such a loaded topic as well. Like for when I'm talking to couples where they have a very established sexual routine, like this is how we do it, he gives me a subtle sign that he's horny by, rubbing my back, and, I give him a subtle sign that I'm, willing or not by rolling over or picking up my book or whatever. So people have these established sex routines, don't they? And anything that breaks that pattern can be quite threatening to address. So one of the pieces of advice that I often give women is we have to think about how to approach intimacy and sex a bit differently because our bodies are different. It takes a different kind of stimulation to arouse us now, and it takes longer. It might be a really good time to explore using vibrators for the first time, for example. And a lot of women kind of go, when I mention that, and they go, oh no, my husband won't be up for that, and he might wonder, if there's something wrong with him, or I think that he's not good enough if I get a vibrator. And so these are very loaded topics, and it warrants a very sensitive, non-judgmental approach by a compassionate couple to sit down and sensitively discuss without, the hurt or accusations or whatever, to be open to improvement. So it can be really tricky, and sometimes they require a mediator or facilitator to have those chats.
Mm-hmm. Oh, it's all about understanding and education, isn't it? And being open and more open with, your doctor and your family, your husband in particular. So, Kelly, thank you so much. I was a little bit concerned that this was going to be a public consultation. But I am going to go on.
You can book in later, Kelly. It's all right.
I will. I'm going to. On your website, I'm going to go through and do the questionnaire, fill the questionnaire in.
Yes. And it's right there front and centre on our web. So if anyone goes onto the homepage, there's a little strip along the top that says take our free menopause assessment. But right now there's also a pop-up that's kind of in your face after the first 5 minutes with a link. And it's actually got, some really good general advice. It'll get you to rate a few symptoms and offer you some sort of generic advice and resources that you can find on the internet for a variety of different problems. But also it'll tell you when and where might be a really good idea to get some expert advice as well.
Kelly, thank you so much. I'll look forward to getting onto that and having a private chat with one of you, either yourself or one of your beautiful doctors. So thank you very much.
They're all fabulous. We're so blessed with our doctors. So they're any one of them, you can't go wrong. They're all fantastic.
Yeah. Are they all women, Kelly? I didn't ask.
So far, yes. Yeah. There was one male doctor who expressed an interest at one stage, but ended up sort of getting overcommitted elsewhere. But I would definitely be open to male doctors working with us. You know, it's just that I think on the whole, it's women doctors who have it more on their radar because it's something that women come to talk to them about more often. And in my case, you know, and the other older ladies who work for us, that we've been through it ourselves as well.
Yeah. Actually, Kelly, I wanted to ask, male menopause. So is there a such thing as male menopause when men go through certain changes within themselves, or is that just something that's
I think it's otherwise been termed midlife crisis. It's when they all go out and buy their sports cars and things, isn't it?
Yeah.
But absolutely, I think absolutely there is. It's called, in a hormonal sense, it's called andropause because they do get declining testosterone levels as well. But men have a range of other issues, and this is going back to the libido stuff and sexual function. It's not always about the female partner. Actually, a lot of male partners have either died if you're older, or they have erectile dysfunction because they've got cardiovascular disease, or they're on antidepressants or a range of medications that kill their libido or lower their testosterone levels. So a lot of women who have low sexual function, it's because of lack of a partner who can actually facilitate. So again, we get back to alternative forms of intimacy, you know, alternative forms of stimulating and pleasuring one another or ourselves, you know, having to explore different options, which can be quite, you know, confronting for a lot of couples to consider changing their repertoire.
And how great to have, you know, someone just, you know, a doctor who's totally focused on that one area that can give you so much great advice and not have things set in stone either. Like if you do need to change things around, it's great, the trial and error.
Absolutely.
Yeah. Kelly, thank you so much. I really appreciate your time. I know what a busy woman you are, and I'll be in touch through the website for sure.
My pleasure. It's lovely to chat to you today, and thank you for talking to me and helping get the message out there about menopause and perimenopause.
Oh, thanks, Kelly. Thanks for all your help with all we regional and remote women who can't readily get to, you know, our normal doctors. So thank you.
You're welcome.
Thank you for watching and listening to my interview. If you'd like to hear more inspiring stories, subscribe to my YouTube channel or my podcast and follow me on Instagram and Facebook at Life Journey TV.